Hi, everyone. Today we are going to discuss how to approach and to interpret ABG, or to discuss principles of ABG interpretation. Yeah, you can come, it's right. I'm sure that most of you or all of you can interpret ABG in a proper way. Just consider it like a rapid review, how to interpret ABG in an easy way and organize steps. So let's start from the beginning. All right, first of all, we have to know that ABG is one of the most important blood investigation which should be done for every patient who's coming with dyspnea or shortness of breath, especially if the patient has respiratory condition like history of bronchial asthma or COPD exacerbation or other obstructive lung disease like bronchiectasis or OSA, obstructive sleep apnea, exacerbation of ILD, severe pneumonia, or severe pulmonary congestion. Other indications for ABG, not VBG, ABG is the most specific, is neurological disorder like shortness of breath or dyspnea in a case of myasthenia gravis, for myasthenia gravis crisis. Also dyspnea with GBS, Guillain-Barré syndrome, because in advanced stage of Guillain-Barré syndrome, the patient may present with respiratory failure. Dyspnea with motor neuron disease. Again, motor neuron disease can be associated with respiratory failure in advanced stage. Drug overdose like benzodiazepine and opioids could be associated with shortness of breath and maybe respiratory failure and bradypnea. So these are the indication to ask for ABG. Dyspnea of unspecific or hypoxia of unspecific cause, like suspected PE, for example, pneumothorax, mucus plug, and lung collapse. We have to be aware of the normal values of ABG, and of course to be written in the ABG script. So PCO2 will be from 4.7 to 6 kPa or 35 to 45 millialkali. PO2 will be from 9.3 to 13.3 kPa or 80 to 100. Bicarb should be between 21 to 28, and O2 should be between 92 and 98%, and basic cyst should be between -2 to plus 2 millimole per liter. This is the normal values of ABG. Basic ABG interpretation rules. Number one, you have to look at the pH. This is step one, pH, because pH will tell you if the patient is acidotic, alkalotic, or normal. And normal pH doesn't rule out acid-base balance dysfunction. It could be compensated. So the first rule, number one, is to look at the pH. If it is low, then the patient is acidotic. If acidotic, you have to calculate the annoying gap, because annoying gap is very important to differentiate between underlying causes of high annoying gap metabolic acidosis or normal annoying gap metabolic acidosis. And we are going to come to this point later on. Number two is to look at CO2, PCO2, because PCO2 will be indicator for if there is acidosis. If it is high, means that there is some sort of respiratory acidosis. If it is low, there is some sort of alkalosis or maybe compensation. Number three is to look at the bicarb. If it is low, it means that the patient is alkalotic or trying to compensate. If it is low, it means that the patient is acidotic or trying to compensate. So these are the main three elements of the ABG you have to look at. Number one is pH, number two is PCO2, number three is bicarb. If the changes aren't in keeping with these levels, then it is likely to be normal, or maybe there's some sort of compensation. We'll come later to know how to interpret or how to know if the patient is compensated or not. So again, the main item here is to look at pH, PCO2, and bicarb. This is the table actually. Okay, this is examples of metabolic or acid-base balance. As according to our rule, number one is to look at to the pH. pH here is low, so probably the patient is acidotic, right? Number two, we have to know if it is metabolic or respiratory acidosis. Here, PCO2 is normal, so this is not respiratory acidosis. Bicarb is low, so this is metabolic acidosis. Number two, pH is high, meaning that the patient is alkalotic. Is it respiratory or metabolic? We have to look at BCO2. BCO2 is normal, so this is not acidotic, right? Bicarb is high, so this is alkalotic. So this is metabolic alkalosis. Metabolic alkalosis. Number three here is pH is normal, so this is normal acid-base balance, or there is some sort of compensation. Let's look to the rule number two, BCO2. BCO2 is high. It means that this patient is retaining carbon dioxide, acidotic. Bicarb is high, so bicarb is trying to compensate. So this is full respiratory acidosis with compensation. If pH is high, is normal, there is full compensation. BCO2 is high, so there is respiratory acidosis with full metabolic compensation. Bicarb is getting higher to compensate. All right. Number four, pH is low, meaning that the patient is acidotic, isn't it? Number two, PCO2 is high. So this is respiratory acidosis, isn't it? Bicarb is normal, so there is no compensation there. So this is just respiratory acidosis. Number five, pH is high, so the patient is alkalotic, right? PCO2 is high. Oh my God, PCO2 is high, so it should be acidotic then. No, PCO2 is trying to compensate because bicarb is high. This is metabolic alkalosis with partial compensation. The PCO2 is trying to be high to compensate, but it didn't compensate yet because pH is still high on the other higher side. So this is alkalosis, which is metabolic alkalosis with partial compensation because CO2 is trying to be high, or the patient is trying to accumulate PCO2 to compensate the metabolic acidosis. Sorry, the metabolic alkalosis, but it cannot be normalized yet. pH is still high. So this is metabolic alkalosis with partial compensation. The other one here, pH is normal. So this is normal acid-base balance, or there is some element of complete compensation. Let's go to PCO2. PCO2 is low. It means that this patient is, washing carbon dioxide. So this is respiratory alkalosis. And then bicarb is low, trying to compensate. So this is full compensation. So this is respiratory acidosis with full metabolic compensation. That's right. Yeah. So bicarb here is normal, so it's either normal or compensated. Let's go to the other two elements, which is PCO2 is low. So this is the respiratory alkalosis, which can happen in most of the cases of hyperventilation. The patient is washing carbon dioxide. And bicarb is trying to compensate, and it succeed to compensate already. That's why pH is normal. This is respiratory alkalosis with full metabolic compensation. The other one, pH is low. So there's acidosis or alkalosis. There is acidosis, pH is low. Let's search for the cause. Is it metabolic or respiratory? So PCO2 is low. It means that When PCO2 is low, pH should be high because this is, respiratory alkalosis. But here PCO2 is low and bicarb is low. So there is metabolic, there is metabolic acidosis, right? But not compensated because pH is still low. The patient is trying to wash carbon dioxide, trying to compensate the metabolic acidosis, but he cannot do that because pH is still low. So there is partial compensation. So this is metabolic acidosis with partial respiratory compensation. The last one, pH is high. So this is metabolic or alkalotic. Sorry, this is acidotic or alkalotic. Alkalotic, right? So there is alkalosis. The question is it respiratory or metabolic alkalosis? Let's look to the other two elements. PCO2 is low. So the patient is washing carbon dioxide. When PCO2 is low, this is respiratory alkalosis, right? And bicarb is high as well, trying to compensate, but it failed to compensate because pH is still high. So this is metabolic alkalosis and, right, with partial respiratory compensation. Yeah, that's right. We are going to get it later. I know it little bit could be confusing, but later on it will be much better. So again, pH is high. This is alkalosis, right? Is it metabolic or acidotic? It is metabolic because bicarb is high, right? And he's trying to compensate by respiratory. This one, the last one is wrong, by the way. If someone told me what the wrong and the last one would be excellent. Metabolic alkalosis, partial respiratory compensation. What would be PCO2 here? Should be high, isn't it? Yeah, that's right. So should be high. Should be high to compensate the metabolic alkalosis. So this should be high.
It's already metabolic alkalosis. pH is high, bicarb rate is high. Metabolic alkalosis, when it's closed down, is trying to compensate.
That's right. Can you tell me what could be this values, interpretation of these values? pH is high, CO2 is low, bicarb is high.
pH is high, bicarb rate is high. It's been metabolic alkalosis.
This metabolic alkalosis, yeah. And the respiratory PCO2 is low.
Yeah, if carbon dioxide is going high, so it's going to
compensate.
If it's going to low, it means we're going to the acidosis.
That's right.
We are going to compensate this.
So what is this interpretation of pH is high, PCO2 is low?
So written is okay.
Is okay. This is right. Okay, so let's do it from the beginning. pH is high, and bicarb is high, right? Metabolic alkalosis, but PCO2 should be high, trying to compensate, isn't it? To go into acidotic level. The patient is training carbon dioxide, okay, to make the blood acidotic to compensate the metabolic alkalosis. So this is mixed metabolic and respiratory alkalosis, because low carbon dioxide will do respiratory alkalosis, high bicarb will result in metabolic alkalosis. So this picture is mixed metabolic and respiratory alkalosis, right? Okay. Basic says is important to detect if this patient has metabolic alkalosis or metabolic acidosis. If there is high basic says more than positive 2 millimole per liter, this indicates normal, high than normal bicarb in the blood, which means primary metabolic alkalosis or a compensated respiratory acidosis. If it is low, base excess less than minus 2 millimole per liter, this indicates there is lower than normal amount of bicarb, and it means that this patient has metabolic acidosis or a compensated respiratory alkalosis. this page or this slide is not very important actually in your stage of FY1. So if it's confusing for you, just ignore it. That's right. Let's discuss every acid-base balance abnormality separately. The number one is respiratory acidosis. What is the ABG pattern in respiratory acidosis? pH will be low. Bicarb will be high, isn't it? And sorry, not bicarb. BCO2 will be high. This in cases of carbon dioxide retention, like, obstructive lung disease, bronchiectasis, exacerbation of bronchiectasis, COPD, or in severe advanced near-death bronchial asthma. Okay. Type 1 respiratory failure. In this case, actually, you'll find that PO2 will be less than K8 and the PCO2 will be low or normal. But in type 2 respiratory failure, we find that PO2 will be low and PCO2 will be high. This is how to differentiate between type 1 and type 2 respiratory failure. In type 1, PCO2 will be normal or even low. In type 2, you'll find that PCO2 is high. What examples of type 1 respiratory failure in a case of PE, for example, a case of pneumonia, a case of asthma, and pulmonary congestion? Type 2 respiratory failure, as we discussed before, you'll find that PO2 will be low, less than 8, and PCO2 will be high. In a case of obstructive lung disease, we have many cases, actually, many examples of type 2 respiratory failure, pulmonary problems like COPD, severe pulmonary edema in advanced stage, of course. The patient is exhausted and he cannot, exhale or cannot wash carbon dioxide anymore. Severe pneumonia, advanced stage of pneumonia. Other obstructive lung disease like bronchiectasis and obstructive sleep apnea. Mechanical causes or mechanical problems which can cause type 2 respiratory failure, including chest wall abnormality or trauma or fracture, which is called frail chest, muscular dystrophies, motor neuron disease or advanced stage of motor neuron disease. In this stage, the patient cannot exhale and is retaining carbon dioxide, a myasthenia gravis crisis. Other central causes like opiate overdose or maybe benzodiazepine overdose and advanced CNS disease. These are the examples of type 2 respiratory failure with carbon dioxide retention. Again, in respiratory acidosis, we have to ask ourselves, is that acute or chronic CO2 retention? Now we agreed that in respiratory acidosis, you'll find pH is low and PCO2 will be high, right? Then you have to look to the bicarb. If bicarb is normal, it means that this acute respiratory acidosis. If bicarb is high, this is partially compensated, right? And this is chronic. Actually, it takes days actually to compensate. So this you'll find it in a case of chronic COPD, for example. You'll find pH is low, bicarb is high, and sorry, PCO2 is high, and bicarb will be high, trying to compensate, partially compensated respiratory acidosis. Okay. There is rule 1 for 10 rule actually to determine if about the compensation. In acute, for every rise of 10 of BCO2 above 40 millialkali, the bicarb will raise by 1. In the case of chronic, every rise of 10 of PCO2 above 40, the bicarb will rise by 4. So again, just to make it simply, in the respiratory acidosis, you'll find that pH is low and PCO2 will be high. Look to the bicarb. If bicarb is high, more than 28 or 29 or 30, this is chronic, probably chronic. This patient is trying to compensate for a long time, which makes bicarb higher on the higher level. If you find that bicarb is normal or is slightly high, this is acute respiratory acidosis. Respiratory alkalosis, number 2. What are the cause of respiratory alkalosis? Respiratory alkalosis mean that pH is high and BCO2 is low. The patient is washing carbon dioxide. And then you'll find that bicarb is normal. What are the causes of respiratory alkalosis? Any cause which can cause carbon dioxide wash, like hyperventilation, any cause of hyperventilation, including anxiety, hyperventilation syndrome, pain. The patient may be pain and anxious. That's why he's washing carbon dioxide, fever, sepsis, or maybe hypoxia because of inacute illness or sepsis. The symptoms and signs of respiratory alkalosis will include rapid respiration. The patient is hyperventilating, tachypnea, palpitations because of an anxiety maybe, numbness and tingling sensation, lightheadedness, and twitching and anxiety. Sorry. Metabolic alkalosis is number 3 of acid-base imbalance. The ABG pattern of metabolic alkalosis. Alkalosis means that the pH is high. Metabolic means that the bicarb is low, right? Okay. What are the causes of metabolic alkalosis? The causes are loss of hydrogen ions due to vomiting, recurrent vomiting, diarrhea, nasogastric suctioning, pareness, excess bicarbonate, secondary to diuretics, or ingestion of alkaline substance. Mixed respiratory and metabolic acidosis. How to interpret that one? What the ABG pattern of mixed respiratory and metabolic acidosis? Acidosis means that pH is low. Metabolic, it means that bicarb will be low. PCO2 will be high. It's mixed, you know. Okay, so what are the causes of mixed respiratory and metabolic acidosis? Cardiac arrest and also multi-organ failure. Okay, mixed respiratory and metabolic alkalosis. What the pattern of that one? Alkalosis mean that pH will be high, bicarb will be high, PCO2 will be low. Right. Okay, causes of mixed respiratory and metabolic acidosis, including liver cirrhosis and in case of excessive diuresis, actually. Hyperemesis gravidarum and excessive ventilation in COPD can cause this mixed picture too. Okay, let's go to the last 4 slides and I'm going to leave you this, interpretation to interpret yourself. This is the case study number 1. pH is 7.14, which is low. Bicarb is 23, which is normal. PCO2 is 6.5, slightly low. Slightly high. And PO2 is 6.6, which is very low. What is the interpretation of this ABG? pH is low, so it means that acidosis. Bicarb is normal, so it is not metabolic, isn't it? Yeah. PCO2 is high, so it means that respiratory acidosis. Is there any compensation there? No compensation because bicarb is normal. Okay. So this is acute respiratory acidosis. Sorry? Type 1 respiratory failure, that's right, because PO2 is low. Sorry, type 2, because PCO2 is high. In type 1, you will find that PO2 is low and bicarb will be normal, or maybe low even. Case study number, so this is the one, this is a case study we just discussed now. The first question to ask yourself, if there any acidosis or alkalosis, pH is low, so pH is 7.1. This is less than, lower than normal, so this is acidosis, isn't it? Question number 2, if the problem is respiratory or metabolic, you have to check the PCO2. PCO2 is high, so it is respiratory acidosis. You have to find and to check for bicarb. Bicarb is normal, so there is no compensation there. There's acute respiratory acidosis. This is study number 2. Okay. Anyone want to interpret this ABG? pH is normal. It's low normal, but still normal, isn't it? Okay. Bicarb is high, 31. You have to look at the other element, which is BCO2. BCO2 is high. So what could be the case? Let's agree this is normal acid-base, either normal acid-base balance or compensated, complete compensated acid-base balance, right? Okay. Here the pH is in the lower side. It could be probably respiratory acidosis, right? Because bicarb is high, with complete compensation. Bicarb is high, isn't it? So what is the interpretation? That's right. Respiratory acidosis with complete metabolic compensation. Here, the first question, how is bicarb? Bicarb is 7.31, so this is normal, right? So we have an acidosis? No, we have, it's normal, not acidosis, actually. I think the one who wrote that one is wrong, which is me. So this is normal, but you know, the lower side, it's still the lower side, isn't it? So number two, what is it? Bicarb, look at to the bicarb. So to BCO2, BCO2 is high. So is this respiratory acidosis with complete metabolic compensation? Bicarb is trying to compensate. It's chronic respiratory acidosis, actually. You find it in a case of chronic COPD. Study 3. pH is 7.3, which is low. BCO2 is 50, which is high. Bicarb is 30, which is high. So what do you think? Partial. That's right. So there is respiratory acidosis because bicarb is high. And sorry, BCO2 is high. Bicarb is trying to compensate. Bicarb is 30, but it's failed to compensate because the patient is still acidotic. So that this is respiratory acidosis with partial metabolic compensation. Again, let's go to the explanation. The question number one, is the patient acidotic or alkalotic? The patient is acidotic, pH is low. Question number two, how is BCO2? BCO2 is high. So this is respiratory acidosis. How is bicarb? Bicarb is high. So there is a trial of compensation by making bicarb is high, but it failed to completely compensate. So this is partially compensated respiratory acidosis. The last case, I'm going to leave it to someone who, yeah, Zoe. Okay, Zoe. Can you interpret that one? pH is 7.5 is high. BCO2 is 47 is high. Bicarb is 32 is high. The pH is alkalotic. Okay. Is it respiratory or metabolic alkalosis? Metabolic alkalosis. All right. With partial compensation. That's completely right. So the first question is pH is high, so the pH is alkalotic. Is it respiratory or metabolic? Here, the bicarb is high, so this metabolic alkalosis with partial compensation because BCO2 is high, but it cannot completely compensate because pH is still high. So this is metabolic or partial metabolic alkalosis with partial respiratory compensation. Thank you. I hope I tried to make it easier for you today. If you have any question at all about metabolic base balance, any question at all?
Yeah, just continue. If like after pH, what we have to look at that carbon dioxide or bicarbonate?
Both of them. Both of them.
You know, like in the last scenario, it was like carbon dioxide was also raised and the carbonate level was also raised.
Yeah.
So it could be like respiratory acidosis, metabolic compensation, or metabolic acidosis with respiratory compensation. Here that.
Okay, you have to go back to the pH. Okay, pH is high, so this is alkalosis.
Yeah.
All right.
Yeah.
Okay, PCO2 74 will cause acidosis, not alkalosis, right? So this is metabolic alkalosis because bicarb is high, isn't it?
Yeah.
So metabolic alkalosis with partial compensation. PCO2 is trying to compensate, but it failed. So you have to go to find after pH, you have to decide this alkalotic or acidotic. And then the bicarb and PCO2 is the one to decide if that metabolic or acidotic, okay? So here we have alkalosis. If it is respiratory alkalosis, PCO2 will be low, not high, isn't it? So this is not respiratory alkalosis at all. Bicarb is high, this is metabolic alkalosis. Bicarb is high, trying to compensate, but it failed. What if, sorry, PCO2, what if PCO2 is normal in this case? Just metabolic alkalosis, no compensation there. That's right. Did you get it? Yeah. Yeah. I didn't try to get it from the beginning. Acid-base balance, how pH, how bicarb is excreted and how H is excreted, you know, because it will make it difficult for you. I tried to get you, you know, cases, you know, cases which we are facing in our clinical field. Thank you for attending today, and can ask for the feedback. It's very important actually to improve our teaching in the next sessions and for appraisal and revalidation as well. Thank you so much for attending today. Thank you.
Thank you.
How do we get feedback?
I think you should. Yeah, the form. Can you get the forms, dear Zoe, from the teaching center, teaching office, please? Can you get the feedback to them? I'll be grateful.